Our next speaker will be Nancy Cox, Director of the Vanderbilt Genetics Institute, Director of the Division of Genetic Medicine, and the Mary Phillips Edmonds Gray Professor of Genetics at Vanderbilt University. Nancy.
Thanks, John, and thanks so much to the committee for inviting me to participate in what has already been a really interesting session. And a lot of key ideas have already been introduced. I am also going to talk about health equity, and in particular, health equity in the context, as a similar context as the last talk, in EHR-based population studies and with EHR-based population descriptors. Next slide. So the take-home messages I'm going to put right up front. We need, next bullet, we need population descriptors of some sort, as has been said, for health equity research. We have serious institutionalized health inequities within medical centers. And I'm going to highlight some that are driven by the use of lab value reference ranges that are simply not appropriate for the diversity of populations that we treat today, that we've always treated, in fact. And I also want to make the point, next bullet, that there is a dynamic relationship between the population descriptors of the past, the population descriptors of the present, and as already been noted, population descriptors that we'll use in the future. And these dynamic relationships reflect changes in our societies and the relationships to both what we think of as genetic and continental ancestries, but also shifting relationships to social determinants of health. So we have to keep in mind that this is a really dynamic landscape, that the landscapes are different in different parts of the world, and there are no simple solutions to complex problems. Next slide. So as I said, most of my research now is in the context of biobanks using exclusively electronic health records as the medical phenome. So in this case, the biobank includes genetic data. So Vanderbilt has about 250,000 people with EHR phenome and genome data. Actually, 120,000 now, but soon to be 250,000. Next, click. But we have another 3 million with just the electronic health record data. Click again. This creates some really good opportunities for virtuous research cycles. With these data, we can make discoveries in the genetic data and look for different kinds of validation in just the EHR data. But we can also do studies in the much larger data set of 3 million with the EHR data, some of which goes back more than 30 years, but on average, we have 10 to 15 years of electronic health record data. We do use population descriptors, and we denote these as EHR-based race ethnicity categories. And that's the best way we can describe them because they've changed over time in the past 30 years, from many fewer descriptors to more now. There was a time when most of these descriptors were defined by somebody at intake who may or may not have asked a person about their ancestries, where their people came from, may have just looked at them and made some decision about what their ancestries were, what their race ethnicities were. More recently, these are self-reported, but because we have such a long history of data, we basically, this is all the information we have, and that's the information we use. So we use these race ethnicity categories, and we use information from the genetics as well, sometimes in conjunction. When we want to study health equity, we may adjust genetic ancestry for race to try to look at more of the specifically genetic components to health inequities. We may adjust race for genetic ancestry to understand better health inequities that reflect the realities, the lived experience of being Black and brown in America today. We use measures of, we use additional measures of social determinants of health, including things like social deprivation indices. We use information related to how much time people have spent in their lives homeless. We have more and more information on trauma in the context of lived experiences of our patients. And all of those we try to incorporate into studies that we do. Next slide. A key recent emphasis, and click again, is that physicians think of the laboratory values that we use as not just measures of disease risk and progression, but as dynamic measures of disease risk and progression. Next click, and click again. But of course, the genetic component to laboratory values is static, even when it makes substantial contribution. Next click. And more than 70% of lab values that physicians order, at least on a monthly basis, are significantly heritable. Next slide. And so we've had a team working on the scope of this problem. Half of heritable lab values have significant differences in their means and sometimes also their variances by EHR reported race ethnicity, leading to a lot of consequences: repeat testing, over and under diagnosis of disease, unnecessary procedures, failing to obtain needed care, short-circuiting needed drug therapies inappropriately, and on and on. And so this is all inadvertent. It reflects the fact that many of the reference ranges for laboratory values were set more than 30 years ago in what we would now consider to be relatively small samples of white males. Next slide. There have been publications noting that some of the common polymorphisms that have relatively large effects on commonly used laboratory values, in this case, white blood cell counts, have disproportionate impact on healthcare in populations that are already marginalized and not always well served in healthcare. So bone marrow biopsies conducted only for low white cell counts can be shown to have no clinical utility in patients homozygous for the Duffy blood group antigen, which is, of course, far more common in populations of recent African ancestries. In places where malaria is endemic, this is essentially fixed in Africa. And so in African Americans, about 60% of African Americans are homozygous for the Duffy blood group antigen. And unfortunately, race-based reference ranges really can't fix this problem, even for this single polymorphism that accounts for about 10% of the heritability in white blood cell counts. This group went on to look at just the EHR reported race categories of Black and white, and can show that about 60% of bone marrow biopsies done only because of low neutrophil counts return no clinically significant results in populations identified, EHR identified as Black, but less than 10% of those white get no clinical benefits from such a bone marrow biopsy. Next slide. And the next one after that, I just said that stuff. But it's not just bone marrow biopsies. We've long appreciated that African Americans who have lupus do much more poorly. One of our physicians has been looking at this and hazard ratios of about 2 for discontinuation of one of the most commonly used early therapies for lupus is seen in blacks versus white. And this is also largely attributable to Duffy homozygosity. And they're now looking at the clinical consequences of this early change in therapy. One of the more effective and less expensive drugs being withdrawn much more frequently in African American versus white patients. Next slide. As I said at the beginning, so this is a genuinely complex problem because much of the time the heritable part of the biomarker is really not what physicians are interested in. But sometimes the heritable part of the biomarker is predictive of the outcomes that we want most to understand. So each biomarker is different with respect to how we might think of solving this problem. But it's not about race. These genuinely are about the alleles that people carry, and most of these polymorphisms simply have different frequencies in different parts of the world, sometimes because of adaptations to local environments, sometimes because of just the kinds of natural climes that occurred in the out of Africa expansions. Next slide. And it really is an iceberg kind of problem. So I've described some of the results on bone marrow biopsies, azathioprine discontinuation, click again. But there's a lot under this, the under part of the iceberg that we're looking at now with cancer chemotherapies, differential outcomes to transplants, and ways of measuring kidney function that have really, really complex problems because of substantially different numbers of individuals that fall outside reference ranges, ranging from twofold differences for US minority populations to 20-fold differences in the groups that fall outside reference ranges. Next slide. It's not the kind of iceberg you can ignore. And I think the combination of things that will have to be done to fix these truly institutionalized problems will be an ongoing health equity issue for some time. Next slide. So however imperfect, please click again, we do need population descriptors to continue studies of health equity. They will and should evolve. Next bullet point. And we have to acknowledge that population descriptors really have a dynamic relationship to genetic ancestries that is really changing in the US all the time, in part because as our population, it is closer to a melting pot than anything else. We have a greater and greater proportion of our population admixed among various different continental ancestries. So it's not just an issue of diversity, it's also an issue of admixture, which has its own interesting challenges in the context of genetic studies. But our population descriptors also have a quite dynamic relationship to social determinants of health as we become a more unequal society that has consequences, as we become a more equal society in terms of economic benefits and access to healthcare that is part of this dynamic relationship. And with that, I'll stop and be available for questions later.